Good afternoon. Welcome, everyone. I'm going to go ahead and get us started. I know there are still folks in the room who are getting their lunch, but I also know there are many people online, and so we don't want to keep folks waiting any longer. We're really excited about our guest today. I'm Susan Hickman. I'm the director of the IU Center for Aging Research here at Regenstrief Institute, and it is my great pleasure to introduce Dr. Momotazur Rahman. And Dr. Rahman is an associate professor of health services, policy, and practice at Brown University. He's an economist whose research focuses on the organization and economic performance of the U.S. healthcare system, and his recent work has been instrumental in understanding how healthcare policies shape outcomes for older adults. Obviously of great interest to me and my colleagues in the Center for Aging Research. Within aging health, his expertise spans a really wide array of topics, from the dynamics of long-term care and nursing homes to the economics of Medicare and Medicaid. I recently shared with my colleagues within the center the featured article in last week's Journal of the American Geriatrics Early View on differences in the setting of initial dementia diagnosis among fee-for-service Medicare beneficiaries, and Dr. Rahman was the senior author of that manuscript. I was really excited to see that. Today, Dr. Rahman will be sharing his work on the effect of institutionalized special needs plans, or I-SNPs, on hospitalization among nursing home residents. And he's indicated he is interested in feedback as well, which I said, you are in the right place to get feedback and input. So without any further delay, I'm going to ask you to please join me in welcoming Dr. Momotazur Rahman.
Hey, thanks for the nice introduction and inviting me here. I think this is my first time doing this invited talk. So, um, yeah, it is great to be here in this nice city, and this is my first time visiting Indianapolis as well. So, thanks. So today I wanted to share some of my work that is strictly in progress. So I just like you'll see like my tables and graphs are like very like rough in shape. Um, but yeah, I thought like these are some interesting results, and it would be great to share it with you and hear your thoughts. Um, so so this is our disclosure.
Yeah.
Yeah. So yeah, I don't have any financial disclosure. All right. Okay. So my contributors, other contributors of the study, Sarah Skozer, um, Yulia, Betsy White, Brian Megarry from University of Rochester, Emily Gadbois from Brown, David Grabowski from Harvard, and Vince Moore at Brown. Um, so this work is being supported by these two grants that we have, and this is an ongoing study, and results are preliminary. And yeah, no financial disclosure, nothing to disclose. Okay, so background. Um, so um, so I wanted to tell you guys that nursing home is a key setting for persons with dementia. So we basically have on any given year about 1.4 million long-stay residents. It used to be like it was in 2018, it was 1.4 million. I think right now it's slightly lower because of the pandemic, and also because of now individuals are we have a in general trend that they're less likely to be institutionalized and more likely to stay in community. But the number is still like around like 1.3 million right now. And 78% of them have dementia. Okay, and these individuals are highly vulnerable to adverse outcomes such as avoidable hospitalization, fall, restraint use, and psychotropic medication use. And also they experience aggressive end of life interventions. Um, so, so most of these individuals are enrolled in fee for service, and they experience conflicting incentives from different payers. Okay, and this I did not realize that this incentive is so important, because I think I understand this after seeing the results. So essentially what happens is that nursing homes serve both post-acute and long-term care patients. And for long-term care patients, payments are much lower compared to post-acute care patients. So post-acute care patients are covered under Medicare Part A, or if you are Medicare managed, yeah. And long-term care, Medicare does not cover. It comes either from individuals out of pocket or paid by Medicaid, or in some cases, um, um, the long-term care insurance. But in general, the payments are much lower. Okay, so nursing homes have the incentive to send these patients back to hospital, where they stay there. They have to stay there for 3 days, come back, and then they start. They're on skilled nursing facility payment scheme again. Okay, receiving post-acute care. Okay, so that's the adverse incentive. Okay, um, so now there is a growing role of Medicare Advantage. Okay, so this is this is a paper that we're working on, basically trying to show like what is the proportion of individuals in nursing homes who are enrolled in Medicare Advantage, overall trend. So if you see like this blue line is for long stay folks. So about 12% or 13% of these long stay folks. So basically these are individual nursing home census on any given year on April 1st, I think, or yeah, or some Thursday of April. Okay, and so we see like these individuals are present in nursing homes, and whether they are short stay or long stay, and then say like whether they are enrolled in MA or not. So can you guys hear me okay? Oh, okay, sorry. Um, okay, so basically likelihood of Medicare Advantage enrollment grew for all individuals. It's much lower for long stay folks, nursing home residents, but still like reached to like 32% currently. Okay, and how about their incentives? So for Medicare Advantage folks, like Medicare plans have to pay for hospital bill, right? So they have all the incentives to reduce hospitalization as much as possible. Okay, so because of that capitated payment, they do AMA beneficiaries do not have that incentive. Okay, but still, the payment gap is there, and nursing home is facing this. Okay, so AMA plan for post-acute care, they pay slightly lower rate compared to TM, okay, but still higher than long-term care. And nursing home still has that incentive, but Medicare, because they're managed care plan, they can intervene, and they may not allow patients, nursing homes, to send patients to hospital. Okay, but to do that, they have to have this coordination aspect. Okay, they have to coordinate with the nursing homes. Okay, and MA plan also have do not have that 3-day hospitalization rule. Um, it could go either way. Like for SNF benefits, so nursing homes can think, okay, like if we send this patient to hospital and stay there for 1 day, come back to us again, and we're on SNF benefit again, SNF payment again. Okay, so it could. I am not exactly sure like what is the name impact of this rule in this context, or how it changes incentive. It could go. One could argue in either direction. So, okay. Now, given that I told you about the incentives of these two groups, this is the hospitalization rate. Okay, so these are hospitalization rate of long stay folks. So this is like basically we're observing them each quarter, and like this is the rate. What is the likelihood of a hospitalization in a given quarter? Okay, and TM guys, traditional Medicare fee for service. So those guys have about 13%. 13% of them are hospitalized. Okay, in a quarter. Okay, for MA guys, it's slightly lower. It's about 10%. Okay, and this remained constant during the whole period. Okay, I wanted to show guys this slide because yes, please. It is not adjusted for resident characteristics. But I would say this, like these are like long stay folks. So yeah, they are fairly homogeneous. Uh, yeah. So this is just the average rate. I mean, like, so the data setup is like we observe each individual in each quarter, population level average. Yes. Yeah. Right. Okay. And there is also this issue of disenrollment. So those guys who enter as MA in nursing home and become long-stay resident, they have much higher likelihood of switching to TM than the other way around. So basically in 2010, we observed like 1.4% of the TM guys who became long-stay resident like switched to MA, whereas those who entered as MA, they had like 14 percentage points likelihood of switching. So that switching trend has declined and sort of merging, converging. Um, so so that so uh, so this is a good sign that MA is playing a bigger role in providing long-term care in nursing homes. Okay. Um, so I think so I wanted to go back to this idea of coordination. So basically, how MA plans, whether MA plans are willing to work with nursing home to improve care. So this is like, I think, one sign that they're doing it. Um, the other thing that I wanted to show that MA plans, we in our prior papers, we showed that MA plans tend to send patients to worse quality nursing homes. And we looked mostly at post-acute patients for that. And if you see the red lines, the dotted line is, so this is the likelihood of entering a high quality nursing home, 4 or 5 star nursing home. Okay. And you can see that when individuals are going for post-acute care, MA guys are less likely to enter a high quality nursing home than TM guys. Okay. And this is true adjusting for neighborhood and socioeconomic factors and everything. Okay. And we see that this gap did not change. Okay. This going up and down thing, it's mainly because um, nursing home star rating assignment changed. So basically, um, uh, so in those years, 2017, there's an uptick just because there are more high star nursing homes in general in the whole country, because nursing homes sort of caught up, like tried to improve their quality metrics and push themselves up to the top 10 nursing homes. And then they changed the threshold again. Now they're again like not so good. Okay. But for long stay, we don't see that gap. Okay. So in general, long stay folks, they are more likely to be in a less likely to be in a this 4 or 5 star nursing home. Okay. But we don't see any difference between MA and TM. Okay. This has been, I think, persistent throughout the whole period. Okay. So this is the background. Okay. Having, so given these two groups, MA and TM, so this is, so I-SNP is this new thing that could potentially have a very large impact on providing high quality care for long-stay residents. Okay, and so some of the features include individuals can join I-SNP only if they are institutionalized. So nearly all enrollment, all the I-SNP plans are focused on nursing home residents. I think they're trying to offer for assisted living, but I'm not exactly sure like how far those initiatives went. Enrollment can happen. Someone can join an I-SNP plan at any time of the year, as long as the person is institutionalized. Okay, became a long-stay nursing home resident. Okay, and one can move from TM or MA, it doesn't matter. Okay, and I-SNPs have the same financial incentives as the typical MA plans, uh, except that it's sort of like uh, designed specifically for nursing home residents. Okay, so what is unique about I-SNPs? So they are MA plans with a specific model, care model. Okay, and this care model centers around advanced practicing clinicians who basically coordinate care, manage acute and chronic illnesses, lead advanced care planning, collaborate with residents, primary care physicians, and communicate with residents, family, and caregivers. Okay, so basically, it not only provides direct care for this for the residents, but also improve coordination between nursing home and the plan. Okay, and one could even argue that nursing homes may also benefit from this added medical presence of the practicing clinician, who, in addition to providing direct patient care, typically also helps to educate and train and mentor nursing home staff. Okay, and these I-SNPs are rooted in the EverCare model. Okay, so this was initiated by Bob Kane and his group. Like they tried to, they did a demonstration, and they found that it reduces hospitalization. Okay, and then Optum basically bought that model, okay, and was trying to implement it. And then United Healthcare, I think, bought Optum, and they have this plan called I-SNP, basically from that origin. And so this UHC I-SNP plan, it's the most prevalent and most matured. And there are also several other companies, MA contracts, that are offering different I-SNP MA plans. Okay, and it's just a lot of I-SNP plans now offered. So this is the overall trend. So it shows the number of plans and UHC plan and non-UHC plan, and UHC plan enrollees and non-UHC plan enrollees. Okay. So and so for okay, and this is my last background slide, which is like, what do we know so far? Okay, so most of the works are pretty old, like came from that EverCare model, work by Robert Kane and that group. And so we were working on it and realized that this David Grabowski and his student like came up with 2 papers, just brand new, published in last few weeks. So these 2 papers basically compared between nursing homes who are identified as like nursing homes with matured I-SNP plans. Okay, and they basically did a difference to show like what is the difference in rate of hospitalization between these 2 types of nursing homes. I wanted to we wanted to frame this question a little bit different. We wanted to see like what is the impact of enrollment of an individual in an I-SNP plan, because we will show that within the same nursing home, there are only 20% of the individuals are joining I-SNP after offering an I-SNP. Okay. And we are also a little bit worried about endogeneity as a maturity as an endogenous variable, just because like, okay, when we are trying to compare between a mature plan, nursing homes with mature plan and those without any nursing home plan. So maturity is a success story essentially. You can compare between these 2 groups only. So very successful I-SNP program versus no I-SNP at all. Okay. So I think we wanted to know the fuller story. Okay. So our objective is to estimate the effect of I-SNP enrollment on hospitalizations, we will look at long-term care outcomes. Okay. Long-term care hospitalizations, like likelihood of hospitalizations. We'll look at end-of-life outcomes. We will distinguish between UHC I-SNP and non-UHC I-SNP. And we will distinguish between individuals who started as MA versus TM, just because they have very different incentives and baseline hospitalization rates. Okay? All right. So data sources. So Medicare claims data and MDS data. We call it okay. I'll come back to that later. So we use the CMS monthly plan data to identify whether this individual is enrolled in an I-SNP or not, or in a MA plan or not. And MedPAR is just for hospitalization. Okay. We also use hospice claim to identify any hospice use, end of life hospice use. Okay. So the cohort. So we structured the data such that we call it a referential history file. So such that like for each day or between two episodelets, we can say like between this date to this date, this person was here. Okay, whether the person was in nursing home or the person was in hospital or using home health or not. Okay, and based on that, we could say like whether this person was a long-stay nursing home resident or not on any given day. Okay, and from there we created a quarter level data, person quarter level data, where an individual is observed for all the quarters when the person is a long-stay nursing home resident. Okay, and see whether this individual was enrolled in an I-SNP or not in that quarter. Okay, and ADRD diagnosis came from the time before they became long-stay nursing home resident. Okay, so we used mainly hospital claims, the hospitalization claims before they started nursing home, and MDS flags to identify persons with ADRD. And basically, we know that this person got admitted to a nursing home, has a ADRD diagnosis, either from hospital claim or from MDS. I think we use the BINAM algorithm, like the person has to have two diagnoses. And we also like excluded delirium and whatnot. Yeah, and then once the person stayed in nursing home for 100 days, the person become long stay, and then we start following. Okay. So for outcomes, we primarily looked at hospitalizations. We also did look at things like the other long-term outcome indicators. I realized that I did not include the results here, but we did not find any effect on those quality measures like vaccination or pressure ulcer or those type of things, or any effect on those outcomes of I-SNP enrollment. Okay, and we looked at end-of-life outcomes like any hospitalization in last 30 days of life, any hospitalization in last 3 days of life, hospice use, any mechanical ventilation use or ICU use in the last 30 days of life. Okay. Treatment, it's a binary treatment, whether the individual was enrolled in an I-SNP or not. Okay, in that quarter. So a quarter is composed of 3 months, we took like whether the individual was enrolled in an I-SNP for the majority of that quarter or not. Okay, at least 2 months or more. So the other explanatory variables, these are so whether the individual was MA or TM at the beginning, and then we also included age, race, gender, dual eligibility, and some clinical characteristics. For long stay analysis, we just used the first months, their clinical characteristics during their first quarter. Okay. And we all our analysis, we did it separately for those who entered as MA versus entered as TM, because we think those two are very different groups in terms of incentives they face, and also in terms of the comorbidities that are counted or reported. So for example, like for MA, they are less likely to receive an MDS assessment. Okay, and that's why if you just consider MDS, MA beneficiaries look much healthier, almost always. Okay, and this is the main model that we want to estimate. Okay, so this is a nursing home fixed effect model. We include year quarter fixed effects and individuals follow-up quarter fixed effect. So we said like we observed an individual over multiple quarters. Okay, we say like indicator for it's the first quarter, this is the second quarter, this is the third quarter, like indicators for those. And we included some beneficiary characteristics. And the main explanatory variable is that whether an individual is enrolled in an I-SNP or not. Okay. The main challenge is that it is a selection variable. Okay, some individuals choose to join I-SNP. Okay, and this could be driven either by the demand side or supply side. So basically, an individual with unobserved needs are systematically more likely to choose an I-SNP. Okay. And the supply side is like MA plans can choose to set up an I-SNP program with particular nursing homes. Okay, so for supply side, this nursing home fixed effects could address that issue, given that we're saying, okay, this is the nursing home we're talking about. And then once you control for that effect of nursing home is taken care of. Okay. But this could actually like increase the damage that is done by the demand side, because then we're comparing within the same facility, like two individuals who joined I-SNP and who did not. So their difference is even larger. Okay. So we propose an instrumental variable analysis. Okay. And our idea is like very simple. Okay. Is that whether this nursing home is offering an I-SNP or not. Okay. So the idea is a person can join I-SNP only it is offering an I-SNP. Okay. And given that we are putting in nursing home fixed effects, so and basically we're using the longitudinal variation. Okay. So in the initial years, there are nursing homes that did not offer I-SNP, and later years they did, and that is driving the enrollment. We can then put the nursing home fixed effects and say, okay, given that this treatment is offered, who wants to uptake it. Like, and we say that only a portion of it, of the individuals who uptakes the treatment, and that allows us to estimate the effect of I-SNP enrollment. Okay. All right. So I wanted to show that how many nursing homes are offering I-SNP here. So there is a growth, particularly from 2016, after 2016. So after 2016, non-HC nursing homes, proportion of nursing homes that are participating in a non-UHC I-SNP plan increased substantially. Okay. And we see a growth in UHC I-SNP as well, but not that much. Okay, but essentially there is like overtime variation. That is all the point that I wanted to make with this figure. Okay, and these are the characteristics of individuals. Okay, so we looked at about 1.1 million long stay individuals in total, and they're observed over like 8.3 million person quarters. Okay, those are the TM guys. For MA, we looked at like about 400,000 unique individuals, and then in total about 3 million observations. Okay, and these are their characteristics and like demographic on the first quarter. Okay, and this is the uptake rate. Okay, this is the enrollment rate. Okay, so those who were MA at admission, they are much more, they have much higher likelihood to enroll an I-SNP. Okay, and overall, more individuals are likely to join UHC I-SNP. Okay, and I-SNP enrollment is growing over time for both those who entered as MA and those who entered as TM. Okay. Okay. So this is the first stage. Okay. So if a nursing home at some point of time offers an I-SNP program, what is the likelihood that a person will take it, will be enrolled? Okay. So if offered a program, 20% individuals will take it. Okay. So if a nursing home offers an UHC I-SNP, okay, about 90%, 19% will take it. Okay. And if about 19% will join an I-SNP program. Okay. On the other hand, if the nursing home offers a non-UHC nursing home plan, these individuals are 1.7 percentage points less likely to join an UHC. So there are this cross effect as well. Okay, and the upticks, like the estimates are much higher for those who are at MA, who entered as MA. Okay. This can be, we can also do this in terms of that's like a static diff and diff. We can do a dynamic diff and diff to show what is the uptake rate. And this is like, I did not distinguish here between UHC and non-UHC, but it basically shows the same pattern. So by the time we're in the first year, about 15% join I-SNP, and then it reaches sort of the steady state level by the second year. Okay, and this is the rate. Like this is the same graph that I showed you earlier with I-SNP, without the I-SNP folks. Okay, so those who joined I-SNP, okay, they are about 8 percentage points less likely compared to TM guys, and about 5 percentage points less likely to have a hospitalization compared to MA guys. Okay, and yeah, I thought like these are huge margins, and the question is that whether this is driven by um, unobserved patient characteristics or observed patient characteristics, or is this truly a plan effect? Um, so so this is the OLS estimate. Okay, what is the effect of I-SNP enrollment using an um, just the OLS regression, not using the instrumental variable, and basically we see that for TM, if you join I-SNP, that you are 5.5 percentage points less likely to have a hospitalization on any given quarter. Okay. So, and then the second column shows that it distinguishes between UHC SNP enrollment and non-UHC SNP enrollment. So UHC have a larger estimate. Okay. Okay, so I'm showing two models here. Like one is nursing home fixed effect model, and the there's beneficiary fixed effect model. So nursing home fixed effect OLS is like I showed you the equation originally, and argued that when you put nursing home fixed effects, most of the bias is coming from individual selection. That individuals who are unobservably less sick may enroll I-SNP. Okay, but given the nature of our data, we observe an individual several quarters, like some individuals we even like observe for 25 quarters. We could put an individual fixed effect model and estimate it. We could put individual fixed effect and estimate this model. Okay, and with that model event, so it's with individual fixed effects, it's like 4.54 percentage points. Okay, and so this is the OLS estimate, and this is the IV estimate. So basically, with IV estimate, nursing home fixed effect model, we get the same, basically the same result as individual fixed effect OLS estimate. And we also estimated individual fixed effect model with the IV, and these results are slightly bigger, but in general, the confidence intervals overlap. Okay. So yeah, this is our main results. I still have so many slides to go. Okay. Let's skip this. We also wanted to show some exclusionary restriction violation, like whether basically looking at, okay, when a nursing home is offering an I-SNP program, do they get different type of patients? Okay, and we don't see any change in patient characteristics, any observable, like detectable change. So so those who are entering this long stay cohort, like their age, chest score, CF score, ADL score, nothing changed with the IV. The only thing that mattered here is the number of follow-up quarters. So we observed that the when I-SNPs were offered in a nursing home, individuals are staying in nursing home for a slightly longer period of time. Okay. The other thing is the I-SNP enrollment, which is needed for the first stage. no difference in survival, 1 year mortality or 2 year mortality. Okay, this is the one test. Um, and by the way, like this is actually a test for exclusionary restriction. So basically this is a difference in difference model. And one of the key assumption is that for difference in difference model is that there is no pre-trend. Okay, we wanted to show there is no pre-trend. Okay, this is not. So before their I-SNP adoption, their hospitalization did not change. But after I-SNP adoption, their hospitalization declined. Okay, for both groups. Okay, um, and I wanted to see if there is any external effect. So basically, if when an I-SNP is offered, do we see any effect on non-I-SNP enrollees? Okay, and this is the individual fixed effect model, and basically we're showing that like how mature is the program and which is a facility level variable, and comparing I-SNP enrollees and non-I-SNP enrollees. So for non-I-SNP enrollees, they did not experience any change in hospitalization in the same facility. But I-SNP enrollees, they experienced lower hospitalization, and it improved over time. So basically, like as the program grew older, likelihood of hospitalization even went down. Okay, but all the estimates are for TM guys are around this like 4% and 5% between, and for percentage points, and for MA guys, it's like 2 to 3 percentage points. Okay. For end of life outcomes, basically took the same individuals and so like focused only on the last quarter of their life. Okay, and these are the characteristics. I want those who joined I-SNP and those on the last month, those who are enrolled in I-SNP and in the last quarter of their life, and compared. So it's roughly the same. And these are the outcomes that we wanted to examine. So showing the overall rates, and this is the enrollment rate. Okay, and again, those who entered as MA, they have much higher likelihood of joining I-SNP, and most of the I-SNP enrollment came from UHC plan. And this is sort of like the first stage, similar again. So basically, if there is an UHC I-SNP plan, individuals are very highly likely to join an UHC I-SNP plan and not likely to join non-UHC plan. It's like a naive regression, you can say. But it's again like this for the end of life folks, it did not go all the way up to 20%. It's around like 15%. Okay, and these are the results. These are the OLS results, and in this case, OLS and 2SLS results differ a lot. For this case, we cannot include individual fixed effects because it's just one observation for an individual. Basically, we see that OLS says that I-SNP enrollees are less likely to have a 30-day hospitalization, 3-day hospitalization, more likely to use hospice, less likely to use ICU, less likely to use any mechanical ventilation, and OLS results are slightly different. Hospitalization effects are large and no effect on hospice use. Okay, And these are seriously large estimates. So basically, we're saying that an average individual, like 30% of those individuals, so 35% of those individuals experience a hospitalization during the last month of their life. And if the person join in an I-SNP, 2/3 of that hospitalization will not occur. Okay. And so it's so large that we went back and forth like trying alternative things, but it is super robust, it seems like. Um, so this is my last slide. Key takeaways. I-SNP really seems like to be working in terms of reducing hospitalization. All right, questions. Sorry, like it was probably super intense.
Because we have a provider-owned I-SNP that has started enrolling and starts January 1st. So those of us in the nursing home setting, not a huge group, but we will see more I-SNP in our state. We certainly have had Optum, UHC for a long time. So one thing I'm curious about is how rich the data is for the I-SNP plans. So much of this impact, I think we believe, is that clinical care model they're required to have. Can you see how many times the NP is seeing the resident, like sort of the intensity of how the model of care is applied in the facility to try to understand if because it makes sense to me, if you have more clinical providers focused on treating people in-house, you'd be able to affect hospitalization rates. We've seen that in our own work. But do you have that kind of data?
We don't have that data.
Okay.
We cannot observe it even if we look at part. So it's not in Part B because they
It's
are
not,
in.
because they're not billing.
Yeah,
Yeah.
and it's not even probably in MA encounter data. We will look at MA
Yeah.
encounter data to see. So this is the first year of this project.
Okay.
So we have plenty of time to do this when we're planning to look at this, and we're planning to do qualitative interviews
Oh, good.
where our team like will go to nursing homes with matured I-SNP, non-matured I-SNP, UHC I-SNP, non-UHC I-SNP to see like how these different models work.
My other question is this big bucket of non-UHC I-SNP. Some of those are provider-owned I-SNPs where the nursing home owner operator themselves has is at risk for Medicare costs. And so the nursing home owner operator is highly aligned with, the success of that model in the facility. And so within the sort of non-UHC, like what are Humana and Anthem I-SNPs and what are provider-owned I-SNPs? And are you able to look at that?
We did not distinguish between provider-based I-SNP yet, but we are planning. We are
Okay,
working
good.
on it.
All right.
Yeah, we Betsy White. So yeah, the author in that paper that you mentioned. She's also she works for Optum. She worked for Optum for a long time, and she is leading that qualitative analysis, qualitative data collection now. So to figure out and also we had a few undergrad students to code which one is provider based I-SNP. So let's see how it goes.
Yeah, there's a question online from David Hagstrom. Arguably, fewer hospitalizations are better, but that is an assumption. Any data or comment about the appropriateness of hospitalization?
Uh, I I think so. Patients basically go to hospital, and typically they would come back with more complications that are related to hospitalizations. And I felt that I did not realize again that this incentive could be this strong, that this many. So essentially, there is literature that says like 75% of all hospitalizations in from among long-stay nursing home residents are potentially avoidable. And I never believed in those estimates because I don't know what it means. But if I-SNPs can reduce um, basically 50% of the hospitalizations without any impact on survival, that's huge. So yeah, so I don't know the exact answer whether it changes how it changes patients' welfare. I have a feeling that it improves patients' welfare.
From online, we have, let's see here. It just scrolled away from me. There it is. I have a question related to the above, also about avoidable hospitalization. Do we know via secondary outcomes that those who did not go to hospital, also, AKA patients counted as a positive outcome, avoided the hospital, also actually received care at the nursing home for what might have been treated in the hospital, even if the hospital isn't the only setting able to treat?
Yeah, that is the question I think Kathleen was asking as well. Like, can I do it from my data? No. So I wish we could have primary care claims, but most of the persons who are know better than I do, and most of them are. And so basically, they told me that not only I will not be able to see them from Part B claims or analogous encounter file because of incompleteness of data, but also it's not being reported. They don't report it as a claim. Um, they're plan employees and plan pays them directly. So yeah, there is no way of knowing.
And one final question. Did you settings in your I-SNP study? So the answer is no.
Thank you.